मुलांना
Good afternoon and welcome to all. Am I audible?
yes ma'am.
Okay. So let's start this physical meeting. Welcome to all. On behalf of Maharashtra University of Health Sciences, Nashik. We are here to discuss today's case on return preterm pregnancy. And to discuss case, we have a PG scholar. She is Dr. Manali Chaudhary from OBGY department, Srimati Kashibai Navle Medical College, Pune. So I will request to Dr. Manali, please share your PPT. And we have experts, Dr. Samir Dharavde, Dr. Seema Mehere, and Dr. Suvarna Kare.
Good afternoon, ma'am. You are going to play my PPT, no?
No, not here. If it's possible to you, please share from your side because it will easy for you to scroll down. Okay.
Okay, ma'am.
हॅलो, कसं करायचं सांगू का? अं, हा, ते खाली एक ऑप्शन आहे. आधी काय कर, तुझी पीपीटी ओपन कर.
But इधर
ते याच्यामध्ये जा. शेअर एक ग्रीन टॅब आहे ना. Is it visible?
Yes.
Visible now? Okay. Let's start, please.
Good afternoon, all. I am Dr. Manali Chaudhary from SKN Medical College. I am a second year PG resident, and I am presenting a case on threatened preterm pregnancy.
Raise your voice.
Acha. Am I audible now?
Audible, but I think your computer audio.
Am I audible?
Okay, fine.
yes, ma'am.
So I am presenting a case on threatened preterm pregnancy. Ma'am, take a slide below. A 28-year-old registered Gravida 5 Para 1 living one with 3 abortions with previous cesarean section, resident of Ambega, educated till 8th standard, belonging to lower socioeconomic status, came with complaints of pain in lower abdomen intermittently, starting from lower back pain, radiating towards the thigh since 2 days. No complaints of pervaginal bleeding, pervaginal watery discharge, or decreased fetal movements. No history of fever or cold. No urinary or bowel complaints. Her LMP was 10th December 22, and by that her expected gestational age was 33 plus 2 weeks. She was married since 7 years in a non-consanguineous marriage with spontaneous conception. Her obstetric history: she had her first pregnancy was spontaneous abortion in first trimester, for which DNA was not done. Second pregnancy, she had undergone a full-term cesarean section for in indication of eclampsia, and she has a 5-year-old female who was delivered by section with weight of 3.5 kg. Third pregnancy, she again had a spontaneous abortion in first trimester, for which DNA was not done. In fourth pregnancy, she again had a spontaneous abortion at in first trimester, and DNA was not done. The current fifth pregnancy is the present pregnancy. Appetite, sleep, bowel, and bladder habits were normal. There were no addictions as told by the patient. There was no significant medical or surgical history. Family history was also not significant. Ma'am, can you take a slide lower? She had a mixed diet with total calorie intake of 2800 kilocalories. Her antenatal history was she was a registered case. Ma'am, slide lower. She was a registered case, and her dating and NT scans were done. There was no history of infections or pervaginal bleeding. She had received folic acid supplementation. The second trimester was also was uneventful. Anomaly scan was done. She had received 2 doses of tetanus toxoid, and she was compliant to oral hematinics. And right now she was in the third trimester. Ma'am, can you take a slide lower? One more lower. One more lower. On physical examination, ma'am, can you take a slide lower? Lower.
Physical
Yes.
exam.
Yes. On physical examination, patient was conscious and well-oriented. She was moderately built with BMI of 25.8 kg per meter square. There was no evidence of pallor, edema, icterus, or cyanosis. There was no evidence of clubbing lymphadenopathy as well. On examination, patient was febrile with pulse rate of 92 per minute and blood pressure of 110 by 70 mm per Hg. Her respiratory rate was 16 per minute. And can you take a slide low? On systemic examination or thyroid examination, there was no enlarged gland or neck swelling noted. Breast examination, physiological changes of pregnancy were noted. And cardiovascular system examination, S1, S2 was heard, and no murmurs were appreciated. Air entry was equal bilaterally with no adventitious sounds heard. For per abdominal examination, patient had emptied her bladder, and we examined her with her legs flexed. On inspection, uterus was distended with umbilicus everted, linea nigra and stria gravidarum seen. No dilated veins or sinuses seen. Previous transverse LSCS scar was seen in suprapubic area, which was healthy. On palpation, uterus size corresponded to 32 weeks. Symphysiofundal height was 32 centimeter. 3 uterine contractions, each lasting for 15 to 20 seconds over 10 minutes were felt. On fundal grip, smooth globular irregular structure was palpated at the fundus. On lateral grip, continuous hard structure was felt on left side, suggestive of back, and knob-like structures felt on the right side, suggestive of limbs. On first pelvic grip, round hard globular mass felt in lower pole, suggestive of cephalic presentation. Head was palatable, and we confirmed our first pelvic grip findings on second pelvic grip, and also on second pelvic grip, we came to know that the head was not engaged. There was no scar tenderness elicited. On auscultation, FHS were heard, which were regular at the rate of 144 per minute in the left spinoumbilical line. On per speculum examination, cervix and vagina was healthy. No discharge or per vaginal leak was noted. On per vaginal examination, cervical os was closed, uninfixed. So my provisional diagnosis is gravida 5 para 1 living 1 with 3 abortion, a registered case with 33 plus 2 weeks by date gestational age with previous section with single live intrauterine fetus in longitudinal live with cephalic presentation with threatened preterm labor.
Okay, Manali. Nice presentation. Case to discuss. So to discuss this case, we have Dr. Samir Darawde. He is a professor from Srimati Kashibai Navle Medical College, Pune. And request to sir.
Okay. So Manali, it is nice presentation, but what to make that it is a threatened preterm and not the established preterm labor? What the clinical history or say the clinical findings you found that it is the threatened preterm?
So she had contractions. She had 3 contractions which lasted for 15 to 20 seconds, which and with no cervical os changes. So we termed it as threatened preterm labor and not established because there was no dilatation which was more than 4 centimeter. So this was a case of threatened and not established preterm labor.
Very good. See, the threatened preterm or preterm labor is very important entity all over the obstetrics because more than 10 to 15% of the deliveries are the preterm. And our NICU beds, more than 50% are occupied with the preterm. So it is the huge burden on the parental side, on the establishment side, and on the doctors or neonatologist side. So somehow we have to find out the various causes. If treatable, we have to treat them, and some things which are not there in our hand, the deliveries can happen. So we have to treat them in the NICU, the babies, we have to save the life of that baby. So it is a huge problem, and so we will discuss one by one. So incidence is around 10 to 15%. So what are the problems? What are the causes or etiological factors we can find out for this case and also in general?
First being iatrogenic, so spontaneous preterm, then other being infections, high chances of preterm in cases of infections, and PPROM if there is a premature rupture of membranes, and also cervical insufficiency.
Okay.
Or if there are any uterine anomalies associated, or there are any fetal anomalies also can be a cause for preterm labor.
Okay. So see the congenital anomalies of the fetus is not viable. These are the different issues. Don't go in detail of that. But what the idiopathic is the most common cause. Nobody knows why the patient goes in the labor, in the early labor. Say the 34 weeks, 32 weeks. Second most common cause is the infection, and that of the most important cause is the urinary tract infection or vaginal infection like the Gardnerella. Next most common cause is the anemia, which is very much preventable, treatable, and which is very serious side effects of that anemia on various aspects, including the preterm labor. So one is the infection, which is treatable and curable. Another one is the anemia. Then other causes of the preterm like the diabetes mellitus or gestational induced like the hypertension or diabetes. These are the another causes. So most common is the idiopathic. So we don't know why the labor, some patient goes in the labor. Probably the investigations are not that much. Probably we lack of the knowledge. Probably we cannot go in detail of the history or in detail of the investigation. Next common cause is the infection, that is the urinary tract infection, and next common is the anemia, and next one is the PIH or gestational diabetes. These are the most common treatable causes. So now see what is the problems with the preterm labor. Suppose the patient delivers at the 32 or 34 weeks. What are the problems? Then we will see the how it preventable or treatable.
uh, the fetus being premature, there are chances of respiratory distress syndrome in the new fetus. Then there are chances of necrotizing enterocolitis, retinopathy of prematurity, and much more common than this is hypoglycemia in the fetus.
Okay.
Uh,
So all
there
organs
can
of the
also be
fetus.
there can also be intraventricular hemorrhage, which can eventually lead to poor prognosis of the baby, leading to cerebral palsy if the baby survives the term gest. If the baby survives, there might be a chance of cerebral palsy ahead.
So in simple words, all organs are immature. All organs of the baby are immature. First is the lungs are immature. So they are not transferring adequate oxygen to any tissue because their surfactant is lacking. They are not opening, alveoli are not opening. So the lungs are immature. Then liver is immature. So it is not able to handle the bilirubin. So result in the hyperbilirubinemia. Kidneys are immature. So they are not able to maintain the electrolytes in the that is another is the fat is not deposited that much, so there is a chance of the hypothermia. So there is no that much of the fat is deposited, or also not a brown fat is there, so they will go in the hypoglycemia. They cannot maintain their calorie intake, or they cannot maintain their nutrition for that purpose. So they suffer from the hypothermia. So intestines are immature. So they may suffer from the necrotizing enterocolitis or other diseases. They cannot digest the food, digest the milk, because milk is that much. They cannot take the milk of the from the mother, and the whatever extra supplementation they cannot digest because the intestines are immature. So and in the brain, they because of the bony cage is not well established, the compression while passing through the vagina or during the process of delivery, bony cage is not mature enough, so brain get compressed, and there is a chance that the intraventricular hemorrhage can occur. So each and every organ is immature, and each organ shows its implication or its fatality towards the baby. So just because the lungs mature at the 34 weeks, and each and every organ start maturing after 32 weeks or 31 weeks. Before that, every organ is immature, and lung matures slightly late, that is the 34, 35 weeks, and the other organs are matured simultaneously. So each organ develops or immature causes the fatality. So how we have to go with the one is the how we prevent the labor. Another is the if not preventable, what we can help to the baby to get maturity. And third is if not able to get maturity, how will it develop in the NICU? Can you slightly enumerate the few factors or complications of mother towards the preterm labor?
Chorioamnionitis.
That is the complication of PROing.
Oh, yes.
Hmm.
We need to find out the cause of preterm labor
Okay.
first. If there is any if there was any vaginitis involved or urinary tract infection, then we need to treat that accordingly.
Hmm. Okay.
If the patient is hypertensive, then we need to treat hypertension as well.
Okay.
Or
So there are
any existing risk factors known which could be a cause of preterm.
So on the maternal side, there are few implications. One is that she is under huge mental pressure or mental stress that she is delivering the small birth weight baby, which is need the NICU care, and it needs the economical, emotional burden on her. First is the mental dysfunction, or mentally she is disturbed because of this process. One. Second is her cervix, vagina is not prepared to deliver. So there is a chance that she will get traumatized during the delivery. So cervical tears are common. Another one is the placenta is not so much mature, so it will not separate so easily. So there is a chance that patient will develop retention of the placenta. And if somebody doesn't know, it will take time to deliver. He pulls out the placenta and may remove the placenta inadequately or incompletely, so that she will develop PPH because of the inadequate delivery of the placenta. So these are the few implications. First and foremost is the mental and economical burden on the mother and on the family side is the first and foremost complication or foremost that concern towards the life of the mother. Then next is the during labor process, whatever the cause of that cause is going to be affect the mother, what is the anemia or PIH or diabetes. But it is also affect the because of the during labor or during delivery process, placenta separates very slowly. It takes 20 minutes or 30, 40 minutes. But somehow few people doesn't understand. They used to deliver the placenta within 5 minutes or 7 minutes and they pull out the placenta. So placenta will come out very in bits and incompletely. So patient develop PPH. So this is the maternal aspect. So we are know the fetal aspects. Now we know the maternal aspect. So now what will you do? Now we have a patient with the previous LACS, 31 or 32 weeks pregnancy with potential threat that she will develop preterm labor and she will deliver preterm baby. This is a threat on us. So what will you do?
First, we
The
will try to
investigation.
localize.
First is the investigations. Then we will administer the drugs.
We will do the blood routine picture to rule to see if there is rise in WBC levels to rule out
Okay.
infections. We'll
Okay.
also send C-reactive protein.
Okay.
Also urine routine microscopy to rule out urinary tract infection. And if there is a history of leak given, we can confirm it over USG. After we are concluded with the investigations, we can proceed with managing by tocalizing the patient. The most common drug being used being the calcium channel blockers, which we use as 30 mg start dose and 10 mg 8 hourly. What we do is called as a short-term tocolysis, which is for 48 hours, in which we buy time so that we can administer corticosteroids to the patient. And as well as in that period of time, if we can also give neuroprotection by giving MgSO4 and tocolysis. If we are successful with the tocolysis, we can go ahead with giving corticosteroids. We can complete the doses of corticosteroids which we have started. So there are two corticosteroids available in India, which is betamethasone and dexamethasone. Betamethasone is given 12 mg intramuscularly, 2 doses 24 hours apart, and dexamethasone is given 6 mg, 4 doses 12 hours apart. In India, dexamethasone is more frequently given because it is more potent and also because of easier availability. Corticosteroids actually help in lung maturation as all, and along with this, we also can start the patient on MgSO4 for neuroprotection. The dose of MgSO4 in threatened preterm is 4 gram IV loading dose is given, which is followed by 1 gram per hour for 12 hours. And if the case is of a previous cesarean section or is there any indication for cesarean section in the current pregnancy, So we can give this dose 4 gram IV stat 4 hours before taking the patient to the section, and we can take the patient to the section after 4 hours of giving the loading dose.
Don't worry about the cesarean section. Patient, we are only going to teach the preterm labor. So don't enter in the pre. So which antibiotic you will prefer, and in which dose, and how much, how long?
So in case of threatened preterm, we opt for erythromycin 250 milligram QID dose for 7 days. And
Okay.
if it is a case of preterm labor, if the patient is in labor, then we go with either it is cefotaxime, and to cover gram negative, we give metronidazole as well.
Gram negative or anaerobic bacteria.
Anaerobic bacteria.
Okay. So we will give erythromycin and metronidazole, or we give the penicillin group of the group,
Drugs.
that is the ampicillin or cefotaxime, whatever the preferred drug, and metronidazole for the next 5 to 7 days. If we are most common treatable cause is the infection. Most common treatable cause is the infection. Easy to treat, easy to diagnose, and we can prevent it. So we have to give the antibiotic. So any preterm, think it is either idiopathic, second is the preterm, and then the anemia. So idiopathic we cannot treat. But at the doubt, we have doubt that maybe infection. Start with the antibiotic and look for the whether there is any anemia there. So what is how you tokenize the patient?
So we can tokenize using calcium channel blockers or beta sympathomimetics. We can also use indomethacin. Calcium channel blockers are commonly used, which nifedipine 30 mg stat dose is given, which is followed by 10 milligram 8 hourly. Or there is one more regimen in which we give 10 mg stat followed and we give 4 doses of 10 mg 15 minutes apart after carefully monitoring the BP, as nifedipine can cause hypotension. We need to monitor BP every time we give the next dose.
So whichever the drugs are available, as far as today's things are concerned, nifedipine is a safe drug, and dose is very handy. We have nothing to do with the one tablet which is available or capsule available in 10 milligram format. So 10 milligram just now, after every 15 minutes, 10 milligram, 10 milligram, and 10 milligram. So within 1 hour, 1.5 hours, we will give the 40 milligram of the nifedipine, and then 20 milligram retard tablet is given for next. How many days you want to give the nifedipine?
7.
Not needed 7 days. 2 to 3 days only are sufficient, because we cannot prolong with the threaten. Once it is established labor, we have to deliver the patient. If it is a threaten, within our aim is to mature the lung. It is not to prolong the pregnancy. It is we cannot prolong the pregnancy, because once there is a hostile environment in the uterus, maybe baby knows more, mother knows more than us. Baby will feel, or mother will feel that the delivering the baby will save her life. So mother is throwing the baby out of her womb, and then we are keeping the baby inside unnecessarily with the whatever the drug, which is not possible unnecessarily, may kill the baby in womb. So baby is wise, he knows when to come out, but just we want to buy time to mature the thing. We slightly prolong the labor, or slightly postpone the delivery, not postpone with the drugs. If it stops within 48 hours to 70 hours, it's okay. If it is not stopping in that time, we can proceed with the delivery. Don't try to post, because it has other implication. We don't know why there is a labor is going on. So never try to give the drugs for a long time, especially when the pregnancy is near or after 34 weeks. If it is below 30 weeks, 31 weeks, you can try. But above that, don't try, because mother knows, baby knows when to come out. So any other drug you know other than dipine?
is beta sympathomimetics. We can do Adilan, isosuxprine,
What is the
also
side? Why they
indomethacin,
are not commonly used?
because of the side effects.
Which side effect?
They can cause tachycardia.
See, the another most common is the two causes, anemia and infection. If the beta mimetics are used in these two patients, patient develops the pulmonary edema, which is the life-threatening serious condition for the mother. So nowadays, beta mimetic, that is the duodolar and whatever the ritodrine or terbutaline are not used so commonly because see the every time we cannot rule out the infection, every time we cannot promptly treat the anemia, and we don't know whether the 8 gram HB is going to develop the pulmonary edema or 6 gram is needed to develop the pulmonary edema with the beta mimetic. So this is the problem. So we are not using so frequently. They are not out of the syllabus, not out of the use, but as far as the frequency is concerned, they are not used so frequently. Depin is more and more good drug, which is more used and more safe. Okay. Anybody else want to ask? So, what is
So,
the
I think there are no queries till now, but stay with us. Very nice discussion. Dr. Ramesh, sorry, Dr. Samir is a guide for Dr. Manali. And so there is a good interaction between student and teacher. Thank you so much to both. Now to discuss from Ayurveda side, we have Dr. Seema Mehri.
Yes, ma'am.
Yeah.
I will share the screen. You will have to make me the host.
Yeah, Dr. Manali, you can stop your screen sharing. Yeah, no, it's from my side. No? Stop here. So now
I
please.
think I have shared it. Can everyone see it?
Yeah,
Yes, ma'am.
it's visible. No problem.
Okay. And shall I start, ma'am? Am I audible?
Yeah, you're audible, ma'am.
Okay. Just start. So good evening to all of you. And at the onset only, I thank everyone for giving me this opportunity. Ayush Department of NIHS, Dr. Geetanjali Karne, ma'am. And thanks to my students also who are here with me. And thank you for a very nice presentation till now, Manali, Dr. Manali and sir also. So today I'm going to talk about Ayurvedic aspect, which is not so active in the sense whatever you discussed till now was the main scenario, like what happens in the labor room and all. So Ayurveda, 1 minute. 1 minute. Next slide, कशी करायची? Diksha, next slide. Just fine. Okay, so ma'am has given me a set format. According to that, I will talk. So this is the underlying etiology. First is that point. Second is diagnostic criteria. Third is line of treatment, and fourth are the limitations of Ayurveda. So I will speak according to that. Now discussing underlying etiology, as you all know, I think everyone is aware of this, that Ayurveda speaks more about prevention rather than cure. So prevention अगर है तो cure अपने आप हो जाएगा. And underlying etiology means all this entity, basically premature labor, preterm labor, or whatever you are saying, threatened preterm pregnancy. All these entities come in Garbha Vyapat, which is described in Charak, Sushruta and Bhagvat as well. And all our acharyas have explained that. So in this case, why I will first speak about these points is because this case typically is a case of preterm labor. Sir, very nice question it was, sir. That sir asked the student that why you are saying it is settled and not it is concluded. Same thing in a different manner is explained in Ayurveda. As long as there is only pain and no PV bleeding and no Garbhashay Mukha Visruti as we call in Ayurveda, we don't say this is in Purva as in Ayurveda. So in this particular case, ANC CTC week, only mild contractions, no cervical duration and PV bleeding is also not there. So how we are going to concentrate on Ayurvedic management? I stop my video. Okay. So hence we will concentrate on Ayurvedic management of premature labor. Other 2 points which I would like to mention here is main is the patient has a history of spontaneous first timer abortion and history of LSTS for eclampsia. So according to Ayurveda, these are the 4 concepts which I will like to talk about. First is the management of preterm labor, Akal Prajayini Avastha or Akal Prasav, which is called. Other entities to discuss are habitual abortion, Garbhasravi Vandhya, some types of Yoni Vyapas, medical disorders in pregnancy, the effect on labor, Garbha Upadrav, and Apanvayu, which is the most important doshas of all, in view of conception and full-term normal delivery, etc. So then this is Prasav, and we are going to talk about premature Prasav handling in Ayurveda. So some of the references are for PV bleeding. Some Grantakaras have given every month जो PV bleeding होती है, every month जो स्राव होता है, उसके लिए उन्होंने treatment दिया है. Some of them have given treatment for Garbhachalana, that is irritable uterus, or increased uterine activity or increased fetal activity. So that way, every month they have given some decoctions, some local applications, some lepas and all are given. So we have Masanumasic Kashayas described by Sushruta as well as Yog Ratnakar and specific Basti, that is the medicated enema, and local applications for irritable uterus by Haris Samhita and Yogirat. So these are the Garbha Vyapas. According to Ayurveda, there are Garbhasrav, Garbhapat. Garbhasrav means first trimester abortion. Garbhapat is second trimester. Upavishtak Nagod and Leena Garbha are nothing but mild, moderate and severe forms of IUGR. Now actually Garbhasrav and Pat, if you see the description, it is first and second trimester. But if you see the shlokas, it is Panchama Shashta Yoga only. One Granthakara has said Chaturtha Mas and one has said third trimester. But if you see by modern medicine, the first trimester only there is a different method of MTP also. And second trimester are different, is a different entity. Then there is one full chapter concentrating on complications of obstetrics only, and that is Sushrutacharya. He is the god of Shalya, and not god actually, like god. So he has explained the whole entity in Mudha Garbha Adhyay, right from Gramya Dharma Yana Vahana, all these shlokas, they are nothing but the reasons why there is abortion. This is Gramya Dharma means having coitus, but which is in a different form or in excess, which will damage the fetus. Yana Vahana means the patient is traveling too much. Adhvagaman, walking on full speed. So these are the, jada khelna, uchal kood karna. Some people used to say, now you are pregnant, so you don't jump and you don't dance and all. So that is what. Katu tikta bhojana shoka, atikshara sevan, all these reasons are there. So because of this, what happens? There are reasons why the fetus it loosens from its stalk and then it comes down into the vagina. So these are the Sanskrit references of this Garbhachalana. Sorry, sir. So this is abortion, and this is Acharya Bhoj who has described Tritiya Stav. This is Harita Vandhya. I think I got some phone call in between. How to cut it? So this is different types of Vandhyatva. In that also there is Garbhasravi Vandhya, in which there is repeated abortions are there. And that's just what I mentioned now, that this patient is having spontaneous abortions. In Ayurveda, we think about these things also. So what it basically means is that according to Ayurveda, it is that there is some weakness in the uterine muscles, or maybe the Garbhashaya, what we can call, and comparatively we can call endometrium in allopathy. So these are the types, different types of Vandhyatva or infertility, in which the Granthakara has explained repeated abortions, habitual abortions. Then this is now the second point of what ma'am has told me, diagnostic methods in Ayurveda. Now, as you all know, there is no HBCBC and all those urine and I said kuch parikshan nahi hai, but we do it, of course. All these things are done in our college. So main thing what the texts have said is they have given more reference to the symptoms of the patient. So in Ayurveda, the main emphasis has always been on the symptoms, and these symptoms are as follows. Tatra purvaktaihi karanaihi. So because of the previous reasons, this is the reasons why the garbha comes out of the garbhashay, kati, vangshan, basti, shulani, rakta, darshanam, cha. So because of the earlier mentioned causes, abortion starts, and there is the pain in the uterus, sacrum and groin region, bladder, and along with PV bleeding. Vitiation of the apanvayu, expulsion of amagarbha, and opening of the orifices of the artava srotas is the reason. Then prasamsaman garbha means what? A slight descent of the fetus. This is what exactly happens in akal prasuti, or what I said before is purvaru. So this is the threatened aspect of preterm labor. Prasamsamane sadaha parshva shula asrut anaha mutra sanga. So all these are the symptoms. What happens when the patient is going in premature labor? The fetus starts its slight descent for expulsion. There is pain along with burning sensation in the flanks, back, excessive bleeding, distension of abdomen, retention of urine. And classification of the types are based on PV bleeding, pain, and stages of the patient's condition. So comparative, if you see, then these are the words in the classics, and the parallel clinical entity is the in the right column. So Vyavasthita Sthiti Yogya Garbha means threatened abortion. In the sense, why it is called Sthiti Yogya? Because the baby is fine. The only thing is we have to stop it from getting out of the body, like going in the process. Prasamsaman Garbha means inevitable abortion. Garbhashesh is incomplete. Apraja, Putragni, Jatagni, all these are habitual. Anavashesha Garbha means complete abortion. Garbhapatan is induced, like MTP procedures. These are also given in Ayurveda, but it is a separate chapter. And Akala Prasav means preterm labor. So these are the references of Akal Prasav. Harita Samhita has stated that all the abnormalities of dosha especially propel the Vayu and the patient. As sir very rightly said, that actually most of the preterm labors are idiopathic. The same thing in a different manner, Harita Samhita has said that if there are, but of course there is a fine slight difference, and that is we live in Rutu Kshetra, Ambu and Beach. So these concepts are there. And if the patient is having Mithya Ahar Vihar and Daiva, so some things are matching and some are different also in Ayurveda. So Harita Samhita has described these reasons for premature labor. References that delivery should not happen in the 8th month has been described. The concept is of Oj. Oj means prana shakti or vital energy, whatever you can call it. But these are the references given in our granthas. So these are the Sanskrit shloks. Then comes the line of treatment. So basically, in Ayurveda, the main thing is the Apanvayu. Apanvayu is main responsible for Shukra and this Shonita, means Artav and Bij coming together, conception, pregnancy, and at the right time the patient should deliver. That is the main responsibility of the apan vayu. If that is gone, if that is spoiled or that is vitiated, then we have to treat the patient. The main treatment for this is Basti. This is medicated enema therapy. It is considered best for managing the deranged apan vayu. Basti is also indicated in Garbhini Paricharya and routine antenatal care also. In the 8th month, in the 9th month, we advise the patient to take Basti. So there are again that Garbhini Paricharya is again another chapter, but still this is necessary to ensure that the baby goes to full term. So this is the shloka of apano apanagaha shroni basti medra rugocharaha. This means that apan vayu occupies the full pelvic region, monitors the functions of the bladder, rectum, male and female reproductive organs, and most important in females, the delivery of the baby. So apart from Sushritacharya, both Harit and Abhav Prakash have described local application packs and decoctions for prevention of premature labor. Some of these are also mentioned as Masanumasic lepas, as I said before. And head low position description is also given in our granthas. This is a shlok. It will come later. Management in Ayurveda is there are some local applications. Shatadhavta Kruta is applied in the intra-umbilical region. In practical, in our college, in our institute, we use Gairic lep, which is also given internally. The powder is given internally also. But basically, the thing is, it is hemostatic and it is cool. According to Ayurveda, it is sheath and it holds or it pacifies the pitta. And pitta is mainly responsible for these things. But here, pitta doesn't mean acidity. Lakshadi oil also should be applied gently. There are oral medicines like Garbhapal Ras, Shatavari, Ashwagandha and Bala, Jivaniya, Bruhaniya, Gand, Garbhastapak medicines. So actually tocolytic है या नहीं उसका research चल रहा है. Because all these medicines are explained as Prajasthapak and Garbha Poshan in Ayurveda. But of course, that time those terms are not there, tocolytic and all these things. But now some research articles are there. Some research is going on these medicines, especially Shatavari, which I think even allopaths know, which is very famous also as a galactagogue. But very few people know that it has a tocolytic action also. So much research is going on in that. So this is management in the head low position. This is the reference. Shayanam tavat mrudu sukha shishirastara samstrinam avunata shiraskam. Avunata shiraskam means the head should be low. And this reference is in Charak Shari. This is head low position is given to prevent fetal loss. Otherwise also we all know why head low position is given. To prevent so Chandan, Dadim, Nakeshar and all these Lepan Chikitsa is given. Again, Garbhachalan Chikitsa, which means that the heightened uterine activity. For that, Harita has given drugs in every drugs are given in every month. So this is the Garbhachalan treatment by Harita. These are the references if students are interested. This is Garbhapal Ras, which is very famous. And all the people, whether they are BMS, whether they are even homeopaths or other fields also. So many GPs I have seen them using this, but actually it is indicated only if the patient is having problems and they should not use it. It is not a OTC drug. So Garbhapal Ras, these are the Masanumasic Kashayas. And limitations, I'll come to the fourth point. Limitations are related to basically access. There are so many patients who actually they are willing also. They come to us, ki humko Ayurvedic hi lena hai. But then there are limitations because all of the centers don't have Panchakara. In institutes we have, but I'm talking of in general BMS practitioners, that everyone doesn't have the access of giving Basti, giving Snehan Swedan and all. So access is not a feasibility in the sense, if you take the risk of treating the patient like this, and if at all, if anything goes wrong, you might be confident that your Basti is acting, your Lepas are acting, your oral medicines are acting. But still, if anything goes wrong, the patient is going to blame you. And there comes the medical legal issues. So the best thing what we nowadays do obstetrics in Ayurveda, what we do is we handle the patient. We are in tandem with or contact with our allopathic consultants. They are honoraries here. And we are always in touch with them. We closely monitor the patient. और अगर ऐसे लग रहा है कि इधर इस point at this point I have to stop, then I'll have to refer the patient. So that is the main. I have given the website number also for research articles of busties in as prevention in premature labor. So what is the way out for Ayurveda? Prevention is better than cure. Of course, Ayurveda focuses on that more. So there is more emphasis on Garbhini Paricharya, Rajaswala Paricharya, menstrual hygiene and all, Sutika Paricharya, etc. So that is the main thing. And when to refer is the close monitoring of the patient after using the medicines, and local application packs is mandatory. Head law is not mentioned anywhere in the sense the description is as a shloka it is given, but this gravitational pressure and all we have inferred it. That is why I have mentioned like that. But in spite of this measure, if there is no relief, then standard treatment of duodenal drip and any other management from the allopathic gynecologist has to be done. And thank you very much. I have rushed a little bit because there are other members also. And if anyone has any queries regarding anything, please, most welcome.
Yeah.
Thank you, ma'am.
Thank you so much, ma'am. PPT, very nice PPT, and almost covered all parts, all points given to you. Thank you so much. But please stay with us. Now, next to
Yes,
this
ma'am.
homeopath part, we have Dr. Suvarna Kale, and she is associate professor from KV Award Homeopathic Medical College, Sanford, Nashik. Dr. Suvarna. Dr. Seema Mahire is a professor and HOD from Sri Rog Prasuti Tantra Department, YMT Medical College, YMT Ayurved Medical College and Hospital Kharghar. And I think Dr. Suvarna Kale is not available to us to discuss this case. So now can open platform for discussion. So if there are any queries, you can ask experts. Dr. Seema and Dr. Samir are here. So what are the highlights of today's discussion? From Dr. Samir, that treatable causes are anemia, UTI, vaginal tract infection. These are the common treatable causes. Is it right?
Yes, madam.
Yes, okay. Then we should prevent labor. First,
We try to prevent.
yeah. And yeah, any other points?
Madam, this whole holistic approach I like very much because the allopathic, homeopathic, and Ayurvedic all coming together and teaching each other that what is the approach. I don't know whether I am not understanding that Ayurveda part, but still I think that what is the basti is the probably removing the all infective sources from that rectal area or anal region, and probably that is helping. And probably that drugs which are used, that is the Shatavari and Ashwagandha, maybe having the some tocolytic effect which extracts years together they are using, that probably has the effect. So we see nobody has a perfect answer. So try this one also. So if the patient benefits from that, whether it is Ayurvedic or whether it is the homeopathic or whether it is the cultural thing, that is my aji used to say that the पपई खाऊ नको, नंतर मटकी खाऊ नको, जड अन्न खाऊ नको, त्यांनी बाळ लवकर डिलिव्हर होतं. कदाचित तेही बरोबर असेल, हेही बरोबर आहे, आणि ॲलोपॅथी हे 100 वर्षातले ते किती बरोबर आहे हेही कुणाला माहिती नाहीये. So this holistic approach is very nice for the student, very nice for the teachers like us, which are mainly thinking of the allopathic. So I like this platform only. So my sincere thanks, whichever developed this platform. I am very much thankful to them. So this is the, and not only the, why the only Ayurvedic people join this student, all faculty should, all that allopathy and homeopathy, all should join this thing. So they will get the outlook that this, yes, something is there like this. Even if they will feel it, something is wrong that day, something is right here, something is wrong here, something is right there. And then new generation will think more and they develop some good remedy for patient.
Integrated
Thank
part.
you, sir.
Yeah. Yes, sir. So, exactly, sir. Thank you so much for your comments. I think preventive part is better in Ayurveda and curative is in modern medicine. So here we can integrate both systems of medicine.
Actually, yes.
Yeah. Is it right?
Yes, ma'am.
Yes, ma'am.
Yeah. So, is there any another query? Or who want to talk anything about this?
I would just like to mention one more thing. I liked what sir said, that there is even I like this idea only, this concept of bringing all the pratis together and discussing the same case. This is really good integrated medicine for students. And basically what we do in our college, sir, is that we, जैसे मैम ने बोला कि इमरजेंसी में एलोपैथी है, लेकिन वो इमरजेंसी न आए इसलिए आयुर्वेदा है. So at present, at least we are working on this, but we, of course, there are so many things given in the, actually I always tell my students कि एक single lifetime पूरा नहीं है, पूरा आयुर्वेद का अभ्यास करने के लिए, because there are so many different concepts given in those granthas, which we have to study and implement. And if we really start implementing them, we might have some miracle drugs like, and to prevent all these things. अभी जो हम duodenal drip लगा के फिर बस्ती देते हैं, that also we can avoid in the future. At present also some people are doing it, even we do it sometime, but that happens in, as you very rightly said, that in false labor, if there are false labor pains, ma'am, then basti will immediately act because they were false. It was sometimes there are false labor pains also. And as sir said that the rectum gets evacuated, the impurities go outside, and that is why maybe it must be acting. जो कुछ भी है, but the research is going on, and I welcome this platform of MOHS and thank you once again.
So much to all participants. Our today's PG scholar, Dr. Manali, for very important and nice case presentation. Dr. Samir, Dr. Seema, so much. And feedback link is there.
Thank you for giving the opportunity.
So, should stop here.
Yes. Thank you so much.